So we should move to the next subject, salvaging the failing heart failure with improved ejection fraction, prognosis and management. To deal with this subject, we have Dr. Suvro Banerjee, and to chair this session, we have Dr. B P Pandey and Dr. S. Ramakrishnan.
Good afternoon, sir.
Good afternoon. Suvro, please.
Okay. Thank you and good afternoon, everyone. It's my pleasure to be invited to give a talk on a new entity, which is heart failure with improved ejection fraction. And I'm going to specially talk about its prognosis and management. Okay, so as you know, in 2016, ESC guidelines classified heart failure into 3 groups depending upon the ejection fraction. And so these 3 groups are heart failure with the reduced ejection fraction, those with preserved ejection fraction, and those with mid-range ejection fraction, which is now renamed as mildly reduced ejection fraction. However, this year they introduced a new term, which is heart failure with improved ejection fraction. And the reason for this was, it was soon realized that those patients with heart failure with the reduced ejection fraction who with treatment improved their ejection fraction, maybe to as high as more than 50%, still they differed in characteristics from those with heart failure with preserved ejection fraction. So it's not just the ejection fraction, it could be something else as well. And to classify patients as heart failure with improved ejection fraction, there must be a previously documented ejection fraction, which is 40% or less. And now the ejection fraction must be more than 40%. And not only that, there has to be a jump of 10 point or more from the previous one. So in other words, if the ejection fraction was 37 and it has now improved to 44%, technically it is not heart failure with improved ejection fraction. Now, this is a new concept, and as you know that heart failure, well, this is why a separate class again, because heart failure with improved ejection fraction was found to have a more favorable clinical biomarker and functional characteristics compared to those with reduced and preserved ejection fraction, but less favorable compared to those in the normal population. In other words, those who never had heart failure. Then the improvement in ejection fraction could be partial, like 40 to 50%, or could be a complete normalization of ejection fraction more than 50%. Recovery usually happens due to guideline-directed medical therapy or device therapy, but sometimes may also happen spontaneously. But what is most interesting is a significant proportion of these patients with the recovered ejection fraction may develop a recurrence of LV dysfunction or relapse, resulting in relapse, recurrence of heart failure events. Now, this heart failure with mid-range ejection fraction are heterogeneous. As you understand, they could represent those patients with a reduced ejection fraction where the ejection fraction is improved to that range, or it could equally be those patients with preserved ejection fraction whose ejection fraction has deteriorated. So to classify patients with heart failure with improved ejection fraction, the LV ejection fraction evolutionary trajectory is very important. Otherwise, we can't say whether it's improved or declined or it's just the same. The improvement usually represents a myocardial remission rather than a true cure of heart failure. And the term improved is used rather than recovered because A, it has been seen that despite normalization of LV ejection fraction, these patients may continue to have heart failure signs and abnormal biomarkers of functional impairment. And B, it's seen that the underlying structural cardiomyopathic process may not improve. And there are 10 to 40% of patients with heart failure with reduced ejection fraction may come to be heart failure with improved ejection fraction. However, there's still lack of consensus regarding the treatment. Now, this is what I have already discussed. So heart failure with the reduced ejection fraction may improve to full recovery, more than 50%, or partial recovery, 40 to 50, or there may be no significant recovery. However, even in those who it has recovered more than 40 to more than 50%, or between 40 to 50%, the clinical characteristics, they differ from that of heart failure with preserved or mid-range ejection fraction. Now, let's move on to the prognosis. The cardio CHOP registry has shown that those with reduced ejection fraction, those with improved ejection fraction, have a survival which is better than that of reduced and preserved ejection fraction, and also they have less heart failure hospitalization. Moreover, those patients where the ejection fraction has improved to a greater degree have better survival than those whose ejection fraction is improved by a lesser amount. And this was also true for heart failure hospitalization. Now, the Penn heart failure study has shown that these patients with improved ejection fraction have an anti-pro-PNP value, which is on average less than that observed in patients with reduced and preserved ejection fraction. And the combined endpoint of death, transplant, or VAD replacement was significantly reduced in those with improved ejection fraction compared to the other two. And these findings have been confirmed by a post hoc analysis of the Valsartan heart failure trial. But what was most interesting is that this showed that patients with reduced ejection fraction who have actually improved the ejection fraction to the mid-range values, that is between 41 to 49%. And if you compare them with those patients who have been diagnosed as mid-range ejection fraction, but their ejection fraction has not improved, if you compare these two, then the survival is better, a lot better than those who have heart failure, who are in heart failure with mid-range ejection fraction, but the ejection fraction has remained static. And this is to say, like, if you move forward, you are going to live. And if you are static, then you may die. This is just to add a bit of, something to the story anyway. So what are the predictors of heart failure? What are the predictors of recovery in patients with heart failure with reduced ejection fraction? So these are could be divided as clinical parameters, biomarkers, imaging, and genetic factors. Clinical factors would include female sex, younger age, non-ischemic etiology, shorter duration of heart failure, lower heart failure NYHA functional class, fewer comorbidities, absence of left bundle branch block, and continuation of guideline-directed therapy for heart failure. So if these are present, there's a higher chance of recovery. Patients who have lower levels of natriuretic peptides, troponin, ST2, and galactine-3, they also have higher chances of recovery. Similarly, those patients who present with lower ejection fraction at the initial evaluation have higher chances of recovery. And if on CMRI, there is absence of your late gadolinium enhancement, that also indicates higher chances of recovery. Into the genetic factors, presence of truncating mutations in the TTNA gene, and absence of activating mutations in the angiotensin converting enzymes or beta-1 adrenergic receptor genes, or absence of pathogenic mutations in some of these locations could also indicate higher likelihood of recovery. Now, it's been seen that 40% of patients with heart failure with improved ejection fraction experience a subsequent decline in ejection fraction. Now, why does a relapse happen? The exact biological explanation is still not known. However, the postulation is the reverse LV remodeling represents a transition to a new, less pathological steady state that allows the heart to maintain LV pump under normal conditions. The reverse remodeled heart, however, retains many of the molecular features of the failing heart and therefore is more prone to redevelop LV function in response to hemodynamic, neurohormonal, or environmental stress. And this article published way back in 2005 actually says that morphological or functional myocardial improvement may occur without widespread normalization of pathological transcriptional patterns. So the real reason may lie in the genes. Now, how to manage such patients with improved ejection fraction? I'll divide into 4 headings. First is whether to discontinue or reduce medical therapy. Secondly, what about CRT and ICDs when the end of life is approached, and whether we need to rechange them or not, reimplant them, and what should be the follow-up protocol. Now, TREAD heart failure is the only study which has looked into this, and whether withdrawal or withdrawal of treatment or reduction of treatment would be is feasible in patients with asymptomatic DCM who have improved ejection fraction. And as you see, the results show that there is a significant increase in cardiovascular events in those patients where the treatment was discontinued. So heart failure treatment should continue indefinitely. Now, there may be some exceptions to this. For example, those who present with peripartum cardiomyopathy or fulminant myocarditis or Takotsubo cardiomyopathy, some of them may actually experience normalization of left ventricular ejection fraction. And so in such cases, reduction or withdrawal of therapy may be considered. Now, this shows that in patients with heart failure with improved ejection fraction, beta blockers, but not RAS or MRAs, were associated with a reduced all-cause mortality risk. This sounds very interesting. However, this is the only study, and I think we need to have more data to say that in heart failure with improved ejection fraction, beta blocker is the one that is most necessary. Now, what about CRT generator change? As a rule, CRT should be maintained because, in fact, replaced because electrical dysynchrony and forward LV remodeling are known to recur with loss of desynchronization. But the issue of ICD replacement is still uncertain. We know that improvement in ejection fraction is associated with lower arrhythmic events. However, some arrhythmic risk remains despite improvement of ejection fraction. And because fatal arrhythmias may occur despite normalization of ejection fraction, continuation of ICD has been recommended independent of EF in patients who have genetic mutations such as LMNA, SCN5A, and FLNC. But what about those who do not have genetic mutations or where we do not have genetic study, because it's not widely available? What to do with them? And that's a very practical question. Now, this publication in JAMA, it shows that patients who had an improvement in ejection fraction to more than 35% during follow-up had a similar mortality benefit with ICD as those whose ejection fraction remained less than 35%. So if you consider this, then possibly it's best to change the ICD as well. When the ERI approaches. Now, the American College of Cardiology has given a statement regarding this, but it's a bit ambiguous. They said that if the ejection fraction has improved to more than 50%, then ICD replacement may still be appropriate, and that although continuation of CRT therapy in patients with prolonged QRS duration is appropriate, replacement of CRT with CRT may also be appropriate. So ultimately, I think it's up to the operator to decide what they are going to do. Now, this is just how to follow up patients who have heart failure with improved ejection fraction. They have to be followed up closely. Now, in all clinical follow-ups, we have to look at take the history, do a meticulous clinical examination and an ECG and NT-proBNP, and then maybe at times an echocardiography, and maybe even less often a CMR if it's available, to look at the function of the heart and some more sophisticated parameters like your longitudinal global shortening. But the patients who are not at high risk, for example, those without persistent left ventral branch block, the genetic DCM or high biomarker profiles or more comorbidities, they may be selected. They may be called for review for a after a longer period of follow-up. So that is something the clinician would decide when to call the patient. So in summary, knowledge of LVF trajectory is necessary to diagnose heart failure with improved ejection fraction. Recovery usually happens due to guideline-mediated therapy or device therapy, but in some cases may happen spontaneously. There are clinical biomarkers, imaging, and genetic factors which predict recovery. Patients with improved ejection fraction have a more favorable outcome compared to those with reduced and preserved ejection fraction, but less favorable to those who never had any heart failure. And despite a complete normalization of ejection fraction, a significant proportion may develop recurrence valve dysfunction. Heart failure treatment in these patients should be continued indefinitely, and a close follow-up of such patients mandatory. Thank you very much.
Thank you, Dr. Suvro Banerjee. It was a fantastic lecture. I think we covered almost all the aspects of improved ejection fraction, which is, I think, we are all seeing quite a number of patients. So my question is, like, when would you consider, at what point of time you will consider discontinuation or reduction of therapy? Or will you consider partial reduction of therapy, like maybe avoid aldactone antagonists first, move on, then in stepwise fashion?
Yeah, I think the only study which we had, it didn't look at partial discontinuation. And I think every case have to be judged on its merit. If I have one of those patients, say, for example, who had a Takotsubo syndrome and have recovered, maybe in such patients, I may gradually think about withdrawing the therapy, maybe by step approach, and observe them very closely. Should they show any signs of deterioration, like increase in NT-proBNP or any of the most sensitive imaging markers, then I may again put them back on therapy. Apart from that, I think it may not be prudent, especially if the chances that the patient may be lost to follow-up, may be best to actually continue them on medical treatment.
Yeah, Suvro, I have one query.
Yeah.
Whether this is a 10-point improvement or it is a 10% improvement in ejection fraction?
It's a 10% actually. 10 point is 10%.
Okay, and second query is, suppose in your clinical practice, you get an ejection fraction of 44%. How often it is going to be heart failure with mildly reduced EF, and whether this is a heart failure with improved EF, or both are the same?
I think this is a difficult question. I mean, unless we follow the trajectory, the evolutionary trajectory, we are unable to say whether it's an improved fraction, improved ejection fraction or a mid-range ejection fraction. So once I find a patient who is in mid-range ejection fraction, and I do not have any documentation of his previous ejection fraction status, then it's vitally important that such patients are followed up closely with repeat echocardiographical parameters to see whether it's actually improving or static or they're actually getting worse. But in any case, I'm not going to stop the medication.
So one question.
One query, because you said it is 10% increase in the ejection fraction. Suppose the ejection fraction was, say, 30%. 10% of 30% is 3%. So at 33%, should we say that?
No, it's not 10%. It's actually, we said 10 points because 1 point.
That was the confusion actually. That's why I wanted to clarify. You please explain this part.
Yeah. So by 10 point, it means actually, see, the percentage is used, the term is used in different sense. When it's 10% increase, it's an absolute 10% increase from the previous echocardiographic ejection fraction. It doesn't mean that a 10% increase, it's not like 10% of 33. No, it's a 10 point. That's why if you look at the definition, they've actually used 10 point. And they have clarified. They have clarified also what they mean by 10 points.
Exactly.
And one question in the chat box that has come is, what is the difference between spontaneously recovered patients and patients who have improved drug treatment? Is there a difference?
Yeah, I think spontaneously recovered ejection fraction happens in a few cases perhaps. And these are the patients probably who are more likely not only to improve, but also perhaps to retain their ejection fraction, at that level. So, but again, we have to be a bit cautious about it. So ideally, these are the patients probably where we can stop the treatment, medical treatment. But again, I think we still do not have that much data to say that it is safe to do so. If we are reducing our treatment and what is, which is often necessary from practical point of view, patients are on numerous treatment, and very expensive treatment. So we are tempted to reduce the treatment. If we really do so, then it's vitally important that these patients are followed up closely.
Yeah, and in a heart failure registry, 16% patients did not have recurrence of low ejection fraction even after stopping the treatment. So it's really a clinical adjudication where to stop, where to reinitiate. And we have seen in our experience that in majority of the patient, it does recur. That means EF does goes down if we stop at least the RAS blockade and beta blockade. I don't know about MRAs and SGLT2 inhibitors, but definitely in majority of the cases, it does recur. We'll close the session.
Yeah,
sure. So 25% to 35% is not fulfilling your criteria. That is very interesting to note. So even 25 to 39%, 14% ejection fraction is not fulfilling. And Dr. Pandey, this is a very strict compartmental definition. So by 144% value, you can never say it is an improved. Improved has got in its definition the whole trajectory of the as Dr. Suvro said, the trajectory. So without the trajectory, you can't attach a terminology of improved ejection fraction. So you have to settle for the term of mid-range or mildly reduced. You can't say improved unless you have got the whole trajectory in front of you.
absolutely.
I think there is a little bit of a confusion growing up. One of the chairpersons, please give the concluding remarks.
I think the whole discussion about discontinuation is only when there is a complete recovery. And there's a partial recovery. I think there is the point of discontinuation is not there. Leave alone the numbers, leave alone the definition. Exactly. That is the most important thing.
Exactly.
Absolutely.
So thank you very much. Suvro, a wonderful talk, and it evoked a lot of debates as well. Good.